Hello, my name is Mohamad Suliman, and my role is to talk to you about the summary of progression in the guidelines of Ramadan risk stratification. First, I would like to thank the organizers for inviting me to give this talk. I don't have any conflicts of interest to make. Going through the history of guidance on diabetes and Ramadan fasting, it was actually back in 1995 when the first guidance came on this. This was from a meeting done in Casablanca, Morocco, which came up with guidance on Ramadan and diabetes. And then 10 years later, the first recommendations from the ADA came in 2005. The ADA recommendations were updated in 2010. And then the Diabetes and Ramadan International Alliance was formed and joined forces with the International Diabetes Federation, the IDF, and came up with their first guidance in 2016. And this IDF DAR guidance was updated in 2021, which is the latest version we have now. I think it would be fair to say that the guidelines are generally based on consensus of expert opinion and also from extrapolation from studies in non-fasting patients. However, in recent years, we have seen more evidence coming from both observational studies and also some interventional studies which were done in Ramadan. Our colleague Salim Bishia looked at the publications which included Ramadan fasting and diabetes between 1989 and up to 2018. And it's quite clear that there is a huge interest in this area because the number of publications on this has been rising steadily, especially since 2005 onwards. One of the very earliest and one of the largest studies on the issue of diabetes and Ramadan was the International EPIDR study. This was a study done in 2001, on Ramadan of 2001, and was published in 2004. And it was a survey of over 12,000 patients with diabetes who were considering fasting in Ramadan. This is from 13 countries. And one of the important findings from that study is that a very large proportion of patients with diabetes actually do fast in Ramadan. So the numbers of those who fasted at least 15 days of Ramadan was 43% of those with type 1 diabetes and 79% of those with type 2 diabetes. So the conclusion from the EPIDR study is that there is a very large proportion of patients with both type 1 and type 2 diabetes who fast in Ramadan. And these large numbers of patients actually represent a real challenge to their physicians. And I think it's a credit to the EPIDR, the early EPIDR study, which very early on suggested the need to provide more intensive education for these patients before fasting, to disseminate guidelines, and also to propose further studies to assess the impact of fasting. So it was the EPIDR study that prompted the first ADA recommendations that were published in 2005. And the purposes of the 2005 ADA recommendations were stated very clearly as threefold. So number one, it was to invite an open dialogue on this very important topic. And they also made it very clear that what they are offering is a set of medical opinions and suggestions. And they also wanted to, number three, to identify topics for research, which is needed to answer the important questions about diabetes and fasting in Ramadan. So this is the categorization of risk from the ADA in 2005. So 4 categories of risk: very high risk, moderate risk, and low risk. And they made it very clear that this classification is based largely on consensus of expert opinion and not on scientific data derived from clinical studies. They suggested that there should be further research to help expand the knowledge about the risk and management issues related to fasting in patients with diabetes. The ADA recommendations were updated 5 years later in 2010. And what prompted the update in 2010 was threefold again. So one of the reasons was there has been some new evidence, especially on issues such as evidence that intensive education actually help people fast safely. Between 2005 and 2010, some new medications came to use, such as the incretin-based therapies, and they were thought to be safe for people who want to fast. And also, it was realized that for the coming years, there will be some areas where the hours of fasting will be very long, in some areas up to 18 hours in the summer time, and there will be special guidance needed for people in these areas. So the 2010 guideline, again, followed the same format of the 2005 guidance. So 4 risk groups with some minor modifications. One of the modifications was adding, as I said, the new safer medications to the low risk group. And then in 2016, the first joint IDF-DAR guideline was published. And what was said here was that based on some recent studies and surveys, the main aim was for this update was to simplify and improve the flexibility in the risk categorization process. So here, instead of 4 groups, it was felt it would be made simple by amalgamating them into 3 groups. So there is category 1, very high risk, category 2, high risk, and category 3, combining the moderate and low risk. And here, for the first time, they used a traffic light system where the people in the category 1 were told they must not fast because the risk of fasting is very high for them. The people in category 2 were told they have permission not to fast and perhaps they should not fast. Whereas people in category 3, they were told that fasting is probably safe and they may fast. Following that, some further developments came, which prompted really rethinking of the guidance and maybe the need for a new update. One of these developments was the realization that many people who are considered to be at high risk were actually fasting. This is a study done by my colleague, Dr. Bashar Effendi, who looked at patients who were about to fast in Ramadan of 2017. They looked at 401 patients, and they identified 147 of them as a high-risk group. And they found out actually 3/4 of this high-risk group actually fasted against medical advice of their health professionals. Again, for type 1 diabetes are considered to be either very high risk or high risk. And a lot of these patients were found actually to fast in Ramadan. This is a study, a survey done by Dr. Fathi Al-Awadi and colleagues in Ramadan of 2016. And they looked at 136 patients with type 1 diabetes. And they found that, again, almost 3/4 of them fasted for at least 15 days of Ramadan. And about half of them actually fasted the full 30 days of Ramadan. So these developments prompted the new update of the IDF-DAR guidelines, which came in 2021. And the authors of this new update said very clearly that this is in light of this emerging evidence that a lot of the high-risk patients actually do fast, and many of them actually fast safely. It was felt that perhaps the previous risk scoring system was perhaps too rigid and needed to be made more flexible and more objective. And one of the reasons, again, that prompted this new update was we realize now there are a lot of potential risk factors, things like the duration of diabetes, the duration of fasting, the motivation of the patient, the level of resources and support for the patient, and so on. It was realized that many of these factors were actually not taken into consideration in the previous risk stratification process that was done before. So the IDF-DAR group looked at a number of risk factors and assigned a risk score to each of them. And this was based mainly on what's available in the literature and also based on their best clinical judgment. So in order to provide guidance for this new risk assessment tool and also to assess what physicians have been doing using the old guideline, a very important survey was done again by my colleague Dr. Bashar Effendi, looking at variability among physicians in risk stratification. So basically what they did here was they created 26 typical case scenarios of patients who were about to fast, and they distributed them to over 300 physicians. These are physicians who are experienced and dealing with patients who are considering fasting in Ramadan. And I'll just give one example of this case scenario. So this is a 17-year-old male. He has type 1 diabetes for 11 years, and this is uncomplicated. He gets a hypoglycemia just roughly about once per month. His current hemoglobin A1C is 7.4%. He is treated with a basal bolus insulin regime. He does some monitoring of his glucose levels as he's advised. He lives in an area where the fasting hours are less than 16, and he does not perform any physical labor. And the questions posed to these physicians were two questions. Number one, what is the risk level for this patient? And would you advise him to fast or not? And 312 physicians responded to this survey. And let's look at the results. So 52% for this case said that he is high risk and he must not fast. 28% said he is moderate risk and maybe he could be allowed to fast. However, he should be told that he has permission not to fast and perhaps he should not fast. And 20%, that's 1 in 5 of these experienced physicians, said actually his risk is low and he is actually safe to fast. So as you can see, there is quite a large variation between different physicians in giving advice to patients on fasting in Ramadan. There are actually potential consequences for this large variability between physicians. It can create confusion for the patients, which is really not good. This confusion can lead to loss of trust in advice. If the patient goes to one physician and they tell them you are high risk, don't fast, and then they go to another physician next door who will say, oh, you're fine, your risk is low, you can fast safely. You can imagine this will create a lot of confusion and loss of trust. And more importantly, it could actually compromise patient safety, which is obviously the most important priority. And possibly there might be even a risk of liability if you give the wrong advice. Let's go back to this patient, this case, and let's score him according to the new risk tool. So he's type 1 diabetes, so he gets 1 point for that. He had type 1 diabetes for 11 years, so he gets 1 point for that, being above 10. And he gets 1 point for having hypoglycemia less than 1 time per week. And he gets 2.5 points for being treated with a basal bolus insulin regime. So the total score for this patient was 5.5, which means he's, according to the new risk tool, he's of a moderate risk. And the IDF DAR risk tool tells us patients who are in moderate risk, they are generally, first of all, they are told fasting safety is uncertain, and they are generally advised not to fast. However, if they insist on fasting, which is obviously, as we all know, is a very common scenario, then if they do insist on fasting, then this is what we should do. They should have a very detailed medical evaluation. They should have their medications adjusted, and they should be advised that strict monitoring of their glucose is very important. And some of the advantages of using this new risk tool is that, first of all, I think it is likely to increase the consistency between different physicians in assessing risk. It will certainly improve the confidence of patients if they are given a consistent advice. And I think very importantly, the risk assessment process can actually be used as an opportunity for education, where we can actually address some of the modifiable risk factors before Ramadan. For example, if someone's control is poor, or if they are not monitoring frequent enough, then they can be shown that they can actually reduce the risk by improving their control before Ramadan, by increasing monitoring, and so on. So the medical guidance has evolved. There has also been attention to the religious guidance, and the first attempt on this was back in 2009, where a religious authority, the Fiqh Academy, issued a decree on exemption from fasting. This was based on the old risk categorization issued by the ADA in 2005. The IDF DAR tools, both in 2016 and the update in 2021, were both backed by religious authority. The details of the religious opinion was published in the online version of the new guideline. This is the fatwa that came from the office of the Mufti of Egypt. So one of the points that was made in the publication about the update of the 2021 guidelines is that this is primarily based on expert opinion and experience. And grade D is perhaps the highest level that can be given to these recommendations. And they strongly suggested that we really need further research to validate this risk stratification tool. And in the next in the last three slides of my presentation, I'll just give you a summary of a study we did in our own institution in the UAE, trying to validate this new risk assessment tool. So this is a study we did at the Imperial College London Diabetes Center in Abu Dhabi and Al Ain. We looked at 647 patients with diabetes who were considering fasting in Ramadan of the year 2021. And we did a pre-Ramadan assessment to quantify their risk. And then we did a post-Ramadan survey to see what happened during Ramadan and whether they fasted and whether they had any problems. So in the pre-Ramadan assessment, we identified about half of them, 51%, to be at low risk with a risk of less than 3. 28% were quantified as a moderate risk with a risk score of between 3.5 and 6. And we identified 1 in 5, that's 21%, as high risk with a score of more than 6. And what happened to them when we spoke to them after Ramadan? Well, when we compared the high risk group with a score of more than 6 against the two other groups, we found that the high risk group were actually less likely to fast the whole month than the other two groups. And they were also more likely to have both hypoglycemia and hyperglycemia as complications of diabetes during Ramadan. So to summarize, I think the risk guidelines have evolved and they have become even much more objective in assessing risk over the years. The new IDF-DAR risk assessment tool, I think there is a good chance it could be predictive of both the ability to fast and also the risk of complications. And however, this risk tool is, we have to remember that it is still based on low-grade evidence, and we certainly need more research to improve the risk, to validate this risk assessment tool and to improve the whole process of risk validation. And thank you very much for listening. Thank you.